I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I'd like to welcome everyone to another episode of Tell Me Where It Hurts. Before I get into today's guest and introduce her, and she is a tour de force, which I think is going to be a great conversation. But advocacy is something our guest today is part of. But I'm going to tell a little Medicaid story about Medicaid advocacy. And this is quite a while ago now. So 20 years ago, when I was in full-time practice in Central Illinois, I had this wonderful woman as a patient. She had a seizure disorder, but extremely compliant, great to talk to, took care of herself. But interestingly, every November, I'd get a call from the emergency room to tell me that Darnetta is in the emergency room again with a full-blown grand mal seizure. And I said, well, what's going on here? She's on Dilantin. Her levels are stable. Everything is fine. Why is she having a seizure? So go into the emergency room, see Darnetta. They've already given her a dose of Dilantin to break the seizure. And I asked her, I said, what's going on? What's the issue here? She's on Medicaid, Illinois Medicaid. And I said, did you not take your medicine, or what's the problem? Well, in Illinois at that point in time, Medicaid had a particular spend for patients. So guess what happened in November? She couldn't get her medication anymore. And she had her seizure, and she would go into the hospital and spend thousands of dollars in a hospital visit to get her back on her regular medications, level, stable, and all that. Well, this actually happened 2 years in a row. After the second time it happened, I picked up the phone and I called the state and the Illinois Public Aid Department at the state. And I said, what in the world is this issue? You won't spend $50 to get this person's medication filled, but you'll spend $5,000 to treat her in the hospital. Well, lo and behold, I got a phone call back saying, we would like for you to come and testify at the state level about this issue. And I said, I'd love to. And I had the chance, very nicely, to basically read the Riot Act to the Illinois Department of Public Aid and how this policy they had was completely ludicrous, even from a financial standpoint. Forget about patient care for a minute, which actually hurt her. It was all about money and all about somebody deciding that that's the way they would run things. Believe it or not, I got it changed. They actually changed the policy. So Darnetta, strikingly, never had another seizure in November, simply because she had her medications. So that's just a little background on one little problem that our guest today deals with somewhat. So I'm really happy to have Kat McDavitt as our guest today. She's the president and founding member of Innsena, and she's the CEO and founder of Zorya Foundation, which is a 501c3 corporation that provides cash grants for healthcare for women, or for childcare in women in healthcare industries. She basically is a tour de force. Kat's the president, like I said, a founding member of Innsena. It's a consultancy supporting organizations operating in the healthcare technology sector with a focus on improving outcomes via Medicaid and public health in underserved communities. She's the head of the consultancy's market access and public affairs practice and is a recognized award-winning leader in data acquisition strategies and negotiation of data use agreements, including the exchange and use of sensitive information. And boy, is that a hot topic right now. In addition, like I said, she is the CEO and founder of Zorya, 501c3 public charity. She is one very busy woman and has her fingers in a lot of pies, but it's an absolute joy to know and to talk with. Kat, welcome to the program.
Thank you for having me, Jay.
Like I said before we got started, I really have been looking forward to talking with you. To get started, you've been in this business for a long time, and you've had a lot of different aspects. Can you give us a little history of how you got started and what got you interested in this, and then kind of what you're doing these days?
Yeah. I started in a little bit of a different place in health tech. I was actually a PR agency girl for a long time at an agency that is no longer, it was acquired long ago. I worked only with healthcare technology clients. As you know, the space is big and small at the same time. So I ended up doing a lot of different things, just working with that very specific category, which I obviously still work in. Started my own consultancy after we were acquired, which is Innsena. I worked Innsena for only a year and a half before I sold it to my now business partner, Leslie Kirk. In 2018, I went and joined a startup called Collective Medical. Series A startup, Kleiner and Bessemer backed, and we did statewide deployments for care coordination technology. Did a lot of data sharing, a lot of data exchange work. And that is actually, I started as the chief marketing officer and moved into a role that we called chief of external affairs because we didn't have a name for all the things that I did. I ended up running policy team, government affairs, and what we kind of called market access, but essentially was I sold to state Medicaid agencies and large convening buyers. As opposed to selling hospital by hospital. So, to do that, you need to have a lot of different ingredients, right? It's how do you understand policy? How do you understand state policy? How can you use that as a tailwind? What sort of influencers do we need to know at the federal level and at the state level? And how do things really just work? So a big relationship oriented sale as opposed to some of these, I wouldn't say hospitals are small sales, but definitely a different type of way to negotiate and get things implemented in markets. So we were acquired, Collective Medical was acquired by Point Click Care in 2020. Point Click Care is the largest post-acute EHR vendor in the country. Wonderful, wonderful people. Then I actually went back to Innsena and built two new practices there and brought Point Click Care as one of our larger clients. So I still do a lot of that work. Much of what Innsena does today is working with states, working with public health agencies, working with digital health vendors that want to figure out how to work in that space. We do a lot of data acquisition strategy, a lot of advising on how you can get different pieces of data from which vendors, and it's kind of a wild world out there right now that's slowly changing because of TEFCA and some of the work being done with the national networks. So we do a lot of that work. We do a lot in public health. Ultimately, what we try to do is Jay, what you were just talking about in your earlier example with advocacy, right? There are big policy level issues that are really hard to change unless one person deals with an issue like you did and starts some sort of a movement. So advocacy is part of the work we do. Especially with those underserved communities, trying to figure out, can we start a movement here? Can we start change? I'll say that we often start things. We aren't usually the ones that are finishing them, right? Typically, these are big, massive initiatives. And we get others that can carry us and have much bigger budgets than we do or our clients along the way. So that's a little bit about Innsena now. We have a team of about 35. We're all across the country. We have no office. We are on airplanes a lot because, as you might imagine, our business is in-person kind of business. And so work all over the country in a lot of different states pretty actively. And then, of course, Zorya Foundation, as you mentioned, is my side passion project. I have a wonderful individual who does most of the work for me, Emma Nelson. She's actually an HIV/AIDS social worker and spends all the time with our grantees, all the moms who apply. And it's kind of the same thing, right? Direct action philanthropy. We give people money for childcare. It's a lot of just, we feel like we can help people get off the brink and get them back on a path to healthy, happy lives and keep women in the workforce, which is our big goal. And then finally, the other fun thing I do is I have the Health Tech Talk Show, which is totally didn't think that was going to be a thing. I do it with my best friend, Lisa Berry, and we pretty much trash talk every Friday at 4:30 Eastern on the internet. So it's a little bit of a lot.
It's a great listen. I recommend people to listen to it. It's got a trash talk, but it's great. It's absolutely.
Don't bring your kids. We curse a lot.
So in your travels across the country, what do you see as some of the biggest challenges that you're running into in what you're doing?
So I'd say with with the work that we do with in different states with public health agencies and even with hospitals, there is so much confusion about how to coordinate care, how to share data, how to get data. That people are very confused about what TEFCA is, even with all of the information out there, because there's misinformation and there's misunderstood information out there, misinterpretations as well. So I've had people believe that they were connected to an HIE when they were using Care Everywhere, right, through Epic, right? I've had people say that TEFCA is truly going to solve all their problems with payers, even though there's no pathway for payers right now, right? I think that's one of the biggest things I spend time educating people on. I also spend time talking about like the fact that you can in fact exchange data for purposes other than treatment if you're not using the national networks and you're working with another source, right? There's so much confusion and it's like really complex stuff. So I think it's easy to confuse people. I think sometimes organizations want to confuse other organizations. And then sometimes it's just really hard to sit there and understand what the heck's going on, which is why I think TEFCA will eventually be a really good thing because it's, I don't think it will ever be the single source of truth, but it is one source of truth.
Well, I was happy to see that the ONC and CMS has finally decided that they're going to make it serious with HTI-1, HTI-2. But you are absolutely correct about the confusion out there regarding both TEFCA and some of the implementation things. One of the things in my old colleagues I talked to quite a bit, I'm from a small town of 19,000 people, Central Illinois, which is really struggling. It has a hospital that's been absorbed by another large hospital, and the access to care has been reduced. You have to travel now to get specialty care. It's been a real mess, actually. So I think the exchange of data is going to help that problem a little bit. It's not going to solve it, but it certainly will help. Speaking of, HTI-2 and interoperability, HTI-2 was 1,076 pages if you read it. It is daunting. And unfortunately, one of my jobs where I work is to do that kind of thing. So I have. So what's your opinion on how this is actually going to roll out? Because we're in the comment phase. HTI-1's done. HTI-2 is in the comment phase. And I've seen some pretty significant pushback on some of the regulations that they put forth. What's your take on that?
Yeah, so I'll start out by saying, we were talking to Brendan Keeler, interoperability, a social media superstar, on our show the other week, and I am in alignment with his concern in general at a high level with HTI-2, which is that it is a late in an administration proposed rule. We've seen this in the past. Sometimes they just poof, go away, right? Like it doesn't ever make it beyond this point. We saw that with the prior auth rule at the end of the Trump administration, right? Even though that rule had tons of support, it poof went away, and then it kind of came back, right? In this administration, a couple of years later. So I think that's a risk too. I think it's how seriously are people taking this? And I think it's always worth taking the time to comment and even if you believe in something, right? Like if you love a part of this rule, please comment on it so that people know it is a matter of public record when you do that. But so I think that's an overall concern is like, is this even going to matter? But there are some things about it. I think in general, what I appreciate about HTI-2 is, I've been following a lot of the drama with the national networks pretty closely, not TEFCA, Care Quality, eHealth Exchange, Commonwealth, right? And like how those are governed. There's been a lot of issues with transparency and some disputes about what is treatment, right? And what I appreciate about HTI-2 is it does look like our great regulators have put in some sections in there that give them more control with TEFCA to identify bad actors, a different pathway for complaints. There's some at least starter language in there about how you can uninvite a Q into their job, right? Which I think is important. Always like makes me scared to think like, oh, we didn't think about that before. Like, ooh. So I appreciate that. There is a lot, I think, information blocking, which the original was my favorite role, even though Don Rucker did tell me that it was a lot like having NutraSweet on my ice cream. I do appreciate it because as someone who lives and believes in the great free private sector and that we can solve problems, I think it gave guardrails on how to play nicely with your competition, but wasn't super, super explicit. Now, of course, the problem with that and what we're seeing and why we're seeing some of those clarifications in HTI2 are that people, the gray area can be really, really big. And so bad actors like the dark side of the gray area. And I think we are seeing some of that. Unfortunately, I think post Chevron, we're going to see a lot of litigation around that as well. What is information blocking? What is this? What is that? So I like that there's more clarification in HDI2. I think they're going to see some pushback on what that means. I think that the exceptions that were included previously for information blocking are so big you can drive you can fly airplanes through those loopholes. And so I think we're trying to close them up a little, but I think they also open up new questions as well. So kind of interesting to watch. And I'm like a little bit bummed out just because that kind of was my favorite rule. I thought it was a good balance between like free market running as well as, trying to balance with like, how do we get people information? Yeah, the two other things that I'm interested in just in general, the public health certification that's in there. I think we need to pay attention to public health. And so I very much appreciate that. I think how that's implemented will be interesting. I think they're going to see some pushback just because, large EHR vendors are going to push back, right, on things that require them to do stuff. And then I am very interested in the section on PDMPs and making them more accessible and open, making them share data a little bit more. I don't know. Those people who have followed me for a while know that I am no fan of the PDMP model. What did you think? What's as a clinician and also health tech leader, what do you think?
I agree. The whole thing is it needs to be revamped and redone. There was a little bit in there with that, but a couple of things that three things that I really liked. One was that the transparency of prior auth for drugs.
Yep.
Because one of the big bugaboos as a practitioner for me was having to pre-auth this list of things, and it took forever, and patients' care was delayed. Anyway, it was a mess. So there was no way to predict anything about doing stuff that had to be authorized. So I loved that particular part. I also liked the clarity that they started to place around women's health, about what you can share, what you can't share, what you have the ability to block, which won't be information blocking, essentially. As a practitioner, I want everything. I want every bit of, if I'm going to treat you for something, I want your entire medical record, whatever's been done, whatever's going on. This puts a little bit of gray area in certain aspects of women's health, which I think is great because of the climate we live in. But I love the clarity of it. They're starting to think about that. The other thing that has come up, which I am absolutely for, is for the first time in any federal regulation, I have seen the word usability. I mean, we've been sharing medical information forever. You put it in a little mail pouch and you send it across the country to somebody in California. So that's not interoperability, but it's sharing of medical information. So we're finally getting to the point where we can get that thing done. So we can get that complete medical picture, and we'll stop duplication. We'll do all kinds of that. The things that really have driven up healthcare costs in my mind. So I really usability, because we're going to get the data tsunami is a real thing. I've talked to my colleagues and they say, well, yeah, I'm interoperable now. I just got 56 screenshots of a PDF to go through for a particular patient. Not usable at all. So I was happy to see the usability aspect of this starting to creep in, because we really just can't keep going what we're doing. We got computers to do this stuff now. We can actually do that.
Oh my gosh. I totally agree. It goes back to what you shared a little earlier about, your small town, some of your colleagues who are still there, how data sharing might help them. Totally agree. But at the same time, it's just what you're saying, usability. Like I often, probably unfortunately in large meetings with some curse words, will often say like, so we're just flinging like effing data around. Like, who cares? Like, because someone in one of these recent meetings was like, Kat, it's not true anymore that people will staple to a patient's chest their medical chart from a sniff to go into a hospital or vice versa. That's not true anymore. We're all, well, like the HIAs are connected, national networks. And I was like, no, just because the data's flinging around and you've got some connections
Right.
does not mean that that data is going to where it needs to go, that it's not in like a 500-page document, and that it's like the information is right there, right when you need it, and it's an application that people actually are going to use. Like, are we logging into separate portals still? Like, so I totally agree. Like, how do you make this information like usable? It's one thing to say it's compliant. We're flinging around data, like we're sending all this dumb ADT or whatever the hell it is. But is it presented in a way that people actually are going to use and quickly? Like, especially in an emergency department, right? Like
Exactly.
the information that those clinicians need is like super fast, high level. How do you get that context where you need it to go? And it's different, in a family practice setting too, So I think that's really important. I agree. I hope that becomes something real and implemented out here.
So let's turn the page a little bit and let's talk about public health, which I was very pleased to see how they're addressing that, because I think we got our pants caught with our pants down with COVID. We just did. There was nothing going anywhere, and what data got sent to CDC wasn't available. They couldn't make any decisions because this wasn't there.
Right.
So I interpreted the new regulation proposals as being a more of harmony of the public health space, meaning people need to realize that public health is a local town, then a county, then a state, and then a state to the federal level. So there's multiple layers of this.
Yeah.
And we got to be able to exchange information, and we got to be able to glean information. What's your take on the new regulations regarding that public health aspect?
I think it's all good. I think anytime we're talking about public health and data exchange in general is going to be a good thing, right? Like that we're actually thinking about it, because like you said, like we kind of didn't until the pandemic. And then we had, we were taking away staff resources at hospitals and having clinicians actually manually type things in every day into the NHSN and whatever the heck, right? It was not great. So I do think, the certification program, I think is good, right? I think that's going to be meaningful. I think it's, might be a little bit annoying for vendors to have to do that. But I think overall, we didn't see a lot of standardization. There was a lot being coordinated with, and, God bless our public health professionals for figuring things out, right? And getting scrappy and getting it done. But again, back to flinging around data, flinging around Excel sheets, using whatever communication channels you had, right, was necessary, but obviously not something that we should count on doing again in the future. So I think it's good. I think there's a delicate balance between, like you said, it goes local to federal, right? And there's layers in between there. And I think, the CDC certainly tries to respect the needs and desires of the states, territories, localities, and tribes, who they work with. And I think that's important too. I think I think what we'll see in some comments letters is from some of those. I always hesitate to use the acronym: states, territories, localities, and tribes, potentially saying, hey, making sure that there's more control at those local levels. I think we'll see a little bit of that. It is always a balancing act, but I think they struck a pretty good balance in the proposed rule.
I think they did too. I was really happy to read what they have done, and the whole thing about electronic case reporting and things like that, making that more uniform, which is kind of what it needs to be. If we're ever going to do public health in the United States, we got to have some platform to do it on. And if we do have, heaven forbid, another pandemic, then we really need to concentrate on how we get that information where it needs to go quickly, so we can analyze things quickly.
Yeah. Yeah, and it's exciting too. I know that I've been skeptical of TEFCA for a long time. I think everybody knows that. I'm responsible for the infamous Q Hins Aren't Real t-shirts, right? Which is like in large part like trying to cut through some of the noise, because there back then too tons of misinformation. No one understood what the hell is going on. I thought the market was confused, and so it was a nice way to like get people to like take a breath and like steal the market for a minute and like get some information out there. But I do think largely through some efforts of some of the larger QHINs, I know Epic has done a lot of work on the public health side of things. There are some public health agencies actually exchanging e-case reporting documents via TEFCA. Like that's like super impressive. Like
Yep.
ECR is something that people have been trying to figure out. So I think we're seeing, I'm a big fan of incrementalism. Things like big things take a long time, and sometimes you don't see the progress right away, but I am super encouraged by that.
What kind of I'm going to call it static because I'm in that part of the world. Um, the business about the EHR companies saying, "Oh, well, this is too fast. This is, I'm a fan for incremental change too, because having gone through both sides of one, like massive versus let's do it piecemeal, piecemeal always works better. But I've had a lot of feedback saying, and I've written this out there saying, I think this timeline is doable. It's not overly stretching to get things in place by January 1st, 28, for heaven's sakes. So what's your
Yeah.
take on that kind of aspect of the pushback we see
With TEFCA specifically?
with TEFCA specifically?
Yeah. I think there's a lot there. I think, being a private representative of the great free private sector, as previously mentioned, I often there are misaligned incentives for a lot of this stuff, right? I'm not generally pro regulation, but I think when you have regulation, it better be clear. And I think that a lot of vendors out there have interests related to data and data as a product that they are trying to figure out. And so TEFCA will cause more than we've already seen commoditization in data, right? So that means prices are going to go down because it should be ubiquitous and pricing is going to have to be at a level and QHINs are going to compete, right? They already are, right? It's kind of the product is very similar, so it's more competing on price. And so I think a lot of the pushback we see is related to, one, of course, obviously you're exchanging patient data. You want to have it correct. Like we just like we're seeing with care quality and some of the, I mean, and some organizations are actually treating some of that those non-treatment purposes that people. So the problem there, just to back up, is care quality currently only allows data, the purpose of use being under treatment, right? What is treatment, right? We do have actual definitions of treatment that our great federal government has given us, but many vendors, the way I say it is, you pound a case of beer and you squint and you say something's treatment, right? How big is the gray area? And we're seeing in some cases those vendors who were pulling treatment for potentially not so treatment purposes or those dark side of the gray area purposes. And there's a lot of scuttle, there's a lot of mistrust now with those networks. And it's people's data, right? It's like people's grandkids' data getting flung around, right? And that is meaningful and we should care about that. I do think some vendors who are resisting TEFCA are maybe focusing on that a little too much and they need to focus on their business model, right? If your entire business model is flinging around data and that's what your product is, I mean, okay, but we've all known this was coming for a long time and organizations need to evolve. That's just how it is. Nothing is ever the same forever. So that's what I would say is there's a little bit of self-interest in some cases with that. There are definitely concerns. I mean, I've heard from actual QHINs saying that like TEFCA is not ready for like mass adoption at this point, right? Like it's slow. We need to make sure that things work. I think that's totally valid, right? Let's work out the kinks with some of the early adopters. I think that's all valid as well. And I think that we're also going to see, I know ONC is pushing, or the new acronym, I don't know how to say it yet, ASTP ONC
Yeah.
announced yesterday, doing, I think, a good job pushing forward on some of the other purposes of use, payment and operations, like trying to figure out how that works. I know public health, they're working hard on that. I think it's going to be very scary for a lot of vendors as they deal with payment and operations, which, a lot of vendors sell to health plans and make a lot of money
Make
that
a lot of
way.
money.
And yeah, and so I think we're going to see, pushback, maybe a little bit of drama llama, some of that. But there's definitely other concerns there too. I think a lot of them are valid, and that's why incrementalism is kind of the jam.
I like talking about the perspective of the scope of this. I've been talking to, well, a lot of my friends are in the rural health space,
Mm.
and I've been getting all this information funneled to me like we're the great forgotten flyover zone here in the middle of nowhere. How's this all going to help me? Because it seems like the industry, at least the healthcare IT industry, has jumped on this bandwagon of everything's going to be solved by AI. All my problems will be solved by an artificially intelligent something. Okay, not true. But that's where the IT business is going. When these guys out in the boondocks, my little hometown, they just want accurate information connected to somewhere, and they really don't care where. So where do you see that going? I mean, we're connected. All the big medical centers are connected. They've been connected in one way or another for some time. Mayo Clinic,
Yeah.
the big referral center of the world, was sending their stuff out. I had my executive physical when I was head of a major clinic at the Mayo, and all went back. My guys couldn't do it. So anyway, what's your take on that? I think we've got some forgotten folks in healthcare, and I'm talking about all practitioners, nurse practitioners, PAs, rural docs. Where are they in all of this? Because it doesn't seem like anybody's either listening to them or getting something together to help them.
Yeah, having done like a lot of go to market, I totally agree. When you're doing go to market for a company that's selling to clinicians, you know what they do? They look at where the big old population centers are, where they can get the biggest deal, right? And then that usually leaves out, unfortunately, those rural parts of the country, unless it's a company that's specifically focusing, like they're trying to fill that white space. It's often like, oh yeah, how do we work with the large academic medical centers, or like a big old Kaiser or something that'll be a big deal, and that's going to be like big deal for our hitting our quota this year. And so it's unfortunate, but I also think as a result, some of these technologies are not even like they're built on urban centers, and
Yes.
as a result, sometimes just frankly don't work. Like they don't translate to a rural setting, or even it might even be urban. But like this is one of the reasons I love the States so much. It's like states are different, right? Medicaid environments are different. Like how you like you were just talking about with Illinois Medicaid, right? Your patient, like you as a human had to figure that out, right? So I think that how do we solve for this problem? I mean, I actually don't have a great answer for you other than I think that we're going to see that rural clinicians. I think like rural healthcare is like phenomenal too. Just like like the scrappiness involved in getting people the care they need. Like there's some people that say like, we don't have an anesthesiologist. So like we have to like bargain with the guy in the next town, when he's off shift to like come and give our moms who are delivering, an epidural, right? Like just like the scrappiness and like the connectedness of rural providers. I think from a like collegial perspective, like you were talking about, you're still friends with all those people who you worked with. I think that's where, and I'm gonna like, because I can't answer your question because I don't know the answer. I'm gonna talk about like what hope I have for
Very
rural
good.
clinicians to teach some of the larger urban centers on how to get things done. I think oftentimes vendors, again, like you're coming in, you're like, oh yeah, this works in New York City, so it's gonna work everywhere. And oftentimes those vendors look at a population level, just like flinging around data is not actually making data usable, right? And they forget about like the human connection and what it actually takes for someone to be able to get something done. And so what I love about rural communities and rural healthcare and the scrappiness about that is we can connect the whole damn country. That doesn't mean we're going to get a social worker to drive from a practice to go to the emergency department where that homeless Medicaid beneficiary just registered, unless it's like that person gives a damn and they have the capacity to do it, right? And we see a lot of burnout associated with some of these high churn urban centers. We see it in rural environments too, right? But I think what those rural providers teach us is how to maintain an actual human connection, and how to do the one-on-one thing that you talked about earlier, right? Calling up Medicaid and being like, WTF, like, why is my patient in the hospital again every November? And I think that's what AI is not going to solve. Maybe eventually it'll be able to do it, but how do we use our brains? How are we actual human beings who are thinking about care? And sure, we have the information in front of us and it's usable now, but that doesn't mean that's how like, you're going to actually treat a patient with these things on the internet, right? You're going to go actually talk to them and figure stuff out. So, this is a long way of dodging your question because like no idea how we stop leaving them behind and getting organizations to care about them in the great world of capitalism, right, where they might be, it's a lower margin type of sale. But I do think I have learned some of the coolest things, and some of the lessons that I've taken to my initiatives are from rural settings where they don't have a lot of money and where they're just getting awesome stuff done because they're humans.
Yep. They're dedicated, very
Yeah.
dedicated. And the
Yep.
folks that I'm talking to, there is some burnout in the rural part simply because of the workload, but they
Right.
truly love what they do. And that's the passion that I think can make a change if we can get it to the right place at the right time, which is
Right.
the
Oh my
hard
gosh,
part.
totally agree. So, just a side story if we have time for it. So, I
Sure.
do a lot of work with Marshall University, Marshall Health Network. Actually, I'm still writing in one of their notepads that they gave me last time I was there. And I do a lot of work with opioids, right? And some of the most amazing solutions that I've seen are from rural communities. And, also the opioid problem is in a lot of rural
Yes.
communities, right? So, so I get hit with that environment quite a bit. And some of the most amazing solutions are born out of like necessity, right? So this is Huntington. This is previously known as Ground Zero, the opioid epidemic. They now call themselves the City of Solutions, and like I freaking believe it, right? Like I bring everybody I can there whenever they'll come with me. And what is amazing there is they do have some technology solutions. They work with, their local HIE is super innovative and trying to get things done. Again, like it's not like they have a bajillion dollars, but they're just like people who care. And anybody who I've met who is working there as a clinician will tell me, I don't have to be here. I'm here because I want to, right? Like I care about this. I'm making a difference. I'm actually seeing people improve. And like, man, oh man, like if like the more I can talk about the work they do, like the more I think it might actually make a difference elsewhere in the country because it's people who care, who are trying hard things, who aren't just following guidelines, and they're making a huge difference because they're human and they care.
That's a wonderful, wonderful story. So we're coming down the end of our time here. Is there anything else you'd like the listeners to know before I ask you my question?
I'll say this, like, this is one of my biggest pet peeves, and one of the things that I think actually make my company successful is like get out into your communities. Like I'll even talk to like these big old nonprofits, and they're talking about saving certain populations, and they've never actually visited a hospital, or they've never visited a community that they're sponsoring. Like get on a freaking airplane. If you can't get an airplane, like drive your car and just be like, and just pick up the phone and say, hey, can I come like spend a half a day with you and just see what you're actually doing? Like holy crap. And vendors, product people, they like a big portion of them have never actually been to observe a clinician's workflow for the
Absolutely.
tools that they're making. Like, holy shit, we could be so much better if people just like went and visited each other. And
Absolutely.
like we can do that now. Like the pandemic's over, allegedly. Like, go visit people, go
Yeah.
spend time with them. And people like I ask a lot of people to hang out. I throw these interesting person parties. I invited you, Jay. You like didn't come. You didn't travel to come to my party. What? But most of the time, people are delighted to spend time with you, especially if it's something that's going to like improve their work overall. Like, just like call some people, just go visit.
Yeah. Well,
That's what I
we
would
could
say.
talk about that for a long time. That's one of my soapboxes that I keep just hammering away on. So I'm going to ask you the question I ask all my guests. If you could change one thing, you're now queen of the universe,
Ah,
and I can wave my magic wand and it's going to happen. What would that be?
this is going to be a little bit like what I just talked about. People actually having relationships with one another. Like in our industry in general, like in our industry, so many people just sit there and they'll say, they'll talk about people as companies, right? Like just call them or write them an email or write them a LinkedIn thing, right? Just like connect with people. I think so many of our issues with data sharing, technology adoption, even like policy issues could be solved if people just had like a drink. It could even be a non-alcoholic drink. Just have a drink with someone, spend some time, get to know them, and like you'll realize like, oh, like this is a real human who's trying to do stuff. I understand their perspective. I can work with this person, and I can get around the barrier that we have. Like if that's one thing I could change, if people could connect more, like holy crap, we would change the whole universe.
Well, you're doing a really good job doing that in what you've done. So if someone wants to get in touch with you, talk a little bit more about what you're doing, How would they do that?
Yeah, so I'd say that the easiest way to find me is on LinkedIn. You can just find me under Kat McDavitt. I'll pop up. Watch our talk show, send me a DM. I do actually read them, even though I have an autoresponder on. So, yeah, that's most likely the easiest way. Or just like out and about. I'm in a lot of Sky Clubs. Like, come say hello if you recognize me. Because I'm connecting one-on-one with
Yeah.
people. That's why I'm in Sky Clubs.
Very good.
Yeah.
Kat, it has been a pleasure, as always, to talk with you. Thank you so much for being on our program.
Well, thank you for having me.
That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys or myself at MedicompDoc, or check out the show notes for links. See you next time.